episode 108. Now, we are with, as always, two very special guests. There's three of us today. We are with my lovely co host, of course, Kelly Kortic, physio extraordinaire. And we are with another physiotherapist. So I'm outnumbered again, but we are with the lovely Beau Walker, Tyrrell. Beau, thanks for coming on, mate.
Thank you for having me, guys.
It's nice to actually just hit record because you and I have probably done this off air, probably about 10 hours worth on phone calls, Instagram voice messages. So I feel like it's just going to be another chat, but the only difference is people are probably going to listen now.
Yeah, I've been
Oh,
saying we need to get Beau on for the last like 6 months because I just sit there and listen to either your voice recordings or your phone conversations back and forth. I'm like, we should just be podcasting this right now. Like, this is such good quality content that you guys are talking about. So I'm glad that we're finally here.
yeah, good. Should have just pressed record, mate. All those late night chats.
Oh man, I could think some of those voicemails. I remember this one time we were just talking on Instagram. This is 10:30, 11 p.m. at night, and we
Mm.
just jumped on Zoom to look at some MRIs of each other that we'd seen, and then we ended up speaking till like 11:30, just chatting about bone stress, just trying to solve the world's problems.
Honestly, there's nothing greater than talking about bones, right? There's no
Yes.
bigger problems in the world.
Now, for the listeners who don't know who you are, give us a spill, what you're doing, where you are, and why you like bone stress.
Yeah. So I'm obviously a physiotherapist, and my name is Beau. Thank you for introducing me. I work in the eastern suburbs in Sydney. I work at a clinic called the Running Room, and we, per the name, treat a lot of runners. Now, being that we treat so many runners, we also see a huge number of bone stress injuries. There have been weeks and days where we've had 5 to 20 bone stress injuries present to the clinic in a single week. So we just see an unreal volume of bone stress injuries. And given that they're just such a more difficult and risky injury, I've taken it upon myself to just try and provide as good of a care as I can. So I'm always a nerd. I've worked in lots of different areas of physiotherapy, and I always try and go out and read and learn a lot more. I found doing that for bone stress injuries was a lot harder. There's a lot of really good evidence out there, but it's not always practical. It's not always super specific, and they don't have all the information that you probably want out there for all the places and all the types of bone stress injuries that you can get. So, being that I also got a bone stress injury late last year, a risky one in the front of my shin that was very troublesome to rehab and also troublesome to get diagnosed, I kind of just took it upon myself to dive in a lot deeper and try to pass on all of that to everyone that I know, all of my socials, everyone that I work with, and hopefully just try and help everyone do a better job at managing bone stress injuries.
Mhm. They're definitely an injury that it, it does seem to sit into a different camp because the consequences, one, of missing them are just so high. We talk about tendons and joints and conditions like patellofemoral pain or plantar fasciitis, and those conditions, the worst case scenario, they can be pretty sore and pretty troublesome, and you might take a little bit of time off. But when it comes to bone stress, the consequences are potentially you could need surgery or you may need 8 weeks off, 10 weeks off, 12 weeks off. So it's definitely a worthy cause.
No, definitely. I think the I used to be a rugby physio, so I'd work with semi-professional and professional rugby teams. And the stakes of that were really thrilling and engaging. And I feel like working with runners, you still have those elite athletes, but you don't always have those same kind of stakes. There's something really gratifying about working with some of these higher risk injuries because you do feel like you make a big difference. I will also say that with bone stress injuries, it's not just that they take so long, um, it's not so much that it's just a hard injury to recover from. Some of them, like a lot of people won't return to sport. Like femoral necks have one of the highest return to sport fail rates of any injury in musculoskeletal healthcare. So I think there's also just that whole burden of you have to do the right thing, and if you mess it up, then you're really disadvantaging your patients.
Mhm. And today we're going to be talking about the myths and the truth of bone stress injuries because, as we all know, not every bone stress injury is the same. There's high versus low risk, there's site specific, and we are thinking of, which I'm going to put you on the spot here. It'd be great to do a series on bone stress because there is just so much to talk about, and there's no way you can cover everything bone stress within the hour. So we're going to talk about the really clear myths and truths. And if you're a clinician listening to this, it's going to be very valuable. But if you're also a patient or a runner or someone wanting to understand a little bit about potentially an injury that you have or that you've heard about, this is going to be the podcast for you.
Let's get it.
Yeah, let's go after it. So to start this one off, and to give some context, I heard this recently and would love both of your opinions on this. It was a recent podcast, and I was listening to someone speak about their training week. And this person isn't a health professional, and they were told by other people in their circles that it is basically impossible for them to have a stress fracture or a stress reaction because their pain warmed up. So we want to talk about the do's and don'ts of clinical assessment in the subjective part, and then we'll speak about the objective. But what are some things that you can include in your subjective questioning and history taking that are really going to rule it in, and some of the questions and things that someone might tell you where you just can't rule out a bone stress injury? What do you know, Kel, as well?
I think it's an interesting topic because it's common in like universities or when we are just sort of introducing ourselves to these different types of injuries like bone stress injuries. You get really like confronted with those rules. Like it doesn't warm up with activity, you'll get night pain, sore with hopping, and it's just like, okay, these are really black and white symptoms that I'm looking for, but it's not always that way. And I think that if you sort of pigeonhole yourself into thinking that every single bone stress injury has to be applied to those rules, then you're potentially going to be missing some early stage bone stress injuries where you could have an impact on this patient maybe only having to deload for a shorter period of time and get back to their sport really quickly. So it makes it hard, like clinically, definitely for us, because it kind of means we have to treat things as bone stress injuries until sort of proven otherwise, in my opinion. But yeah, I think it's common to hear things like that, and I think it is where bone stress injuries do have a little bit more nuance to them.
Beau, what do you think? Someone says, I've warmed up, it's impossible to be a bone stress injury. To be fair, your antenna has to be up because you are the bone stress guy.
Yeah. Well, like I said, there have been days where I think one day we had 4 confirmed femoral neck bone stress injuries in like the span of a few hours at the clinic. And all of them were confirmed on that day via MRI. Like we just see so many. I think you're definitely right, like spot on, nail on the hammer on the head of the nail there, Kelly, where if you're treating runners or dancers or like really competitive gymnasts, populations where it's so common to get bone stress injuries, you pretty much are suspecting a bone stress injury in those populations until proven otherwise. If I was to tell you that like 20% of all runners could have a bone stress injury at some point, then that's probably going to mean that, or 20% of all the injuries that runners will get can be bone stress. That automatically just shifts up how much we're looking for them. I would say, yeah, as soon as someone in the subjective history is telling me that they have night pain, they have very prolonged pain after loading, or they have focal sharp pain during loading, my antenna's really, buzzing up. But it is so common in bone stress injuries for them to either be diffuse and dull when they're in the earlier stages, or if they're a deeper bone, they're not superficial. It's also common in certain types of bone for that pain to be diffuse and spread out. And it's also not uncommon for some bone stress injuries to never actually become that painful. A lot of the high risk bone stress injuries can be quite vague in their symptoms and small. And if we're potentially having some fractures that aren't that painful, we also can't be ruling out that some of these fractures might even be warming up, and some of these bone stress injuries might even be warming up. Because if I could tell you that a fracture couldn't hurt, right, or doesn't hurt very much, then you can also bet your ass that some of these lower risk, smaller bone stress injuries can also warm up. Pain is realistically a complicated thing, and it applies to all things. We see in most injuries that they can have warm-up phenomenon, even in ITBs that are very, highly innervated, very pain-sensitive structures, they can warm up. Why would we not think that bone can also warm up? In the clinic, we've probably seen in the past 6 months about 10 or 12 bone stress injuries that are confirmed on imaging that demonstrated a warm-up phenomenon. I will say, I do think in bones, it's probably less common for them to warm up. So if someone is saying it's warming up, you maybe are going, oh, it's maybe a bit less likely. But if they're also still telling you all these other factors, or something's just not sitting right with you, like that gut feeling that you can sometimes get where something just feels wrong with a patient, or there's just other signs that are just clearly outweighing that warm-up phenomenon, I would be saying that it's a very small piece of the pie and it should not be used to rule out bone stress injuries.
Yeah, for sure. And I often say to patients, like, look, I hope that I'm wrong, but based on our clinical assessment today, there's not enough in this that would convince me that you don't have a bone stress injury. So we're going to investigate it and look, it might come back as something else like a tendon or whatever. And that's great. That means that we can get you running sooner. But if the risk is just too high if we miss it. So I'd rather, investigate aggressively and then know for sure that that's exactly what we're dealing with or not for that reason.
Definitely, definitely. And we see all the time that you can go and get a scan and it can come back when the patient has not very much pain and it can be quite a significant bone stress injury, or they can have a heap of pain and it can be quite a small bone stress injury. So imaging is always helpful to really garner what is actually going on, because sometimes that pain system is just not reliable.
It's
And yeah,
so tricky. Hey, like I was presenting on bone stress injuries to some runners yesterday, and I was just talking about, the fact that pain is pretty much the only thing that we can guide treatment off for these injuries once we've confirmed it, because it's like that's the only thing that we can go off. Like it has to be symptom free. And what we know about pain is that it's so variable and so many things can influence it. But in the context of bone stress injuries, that's kind of all we can use. But then, like, I don't think I've had a runner who hasn't said to me, who has had a confirmed bone stress injury, that hasn't said, oh, this isn't as painful as I would expect a bone stress injury to be. And it's like, yeah, it doesn't, because it's a bone stress injury, it doesn't mean that it's a 10 out of 10 pain. Like it often is something that you can keep running through, and that's how they do progress to stress fractures.
yeah.
I wanted
So
to add in there what you mentioned about like a stress fracture versus a bone stress. Two-part question. Would you see genuinely more bone stress if we think of it on a continuum where, let's say, stress fracture is near the end? Would you be seeing more bone stress, and then would you also then say that they are more likely to warm up? So it's not that common for people to be able to push it all the way to the end if it is sore. They might get it assessed prior to that, and potentially it can warm up because there isn't that fracture in through there, or it's more edema related.
yeah, so I think the majority of the fractures that we've had that have warmed up in like low risk categories have all been grade 1 to 3. We've had one femoral neck that was a grade 4A, which isn't actually the right classification for a femoral neck, but that's just what the radiologist reported. That did warm up. So like sometimes I think fractures might be warming up, and particularly in high risk places, they can often warm up, even if there is a fracture. But the majority of the time, it's just really that lower level edema, that lower level like pain stimuli in the actual more like chemical irritants is more likely to warm up. When we talk about the bone actually breaking and there being more mechanical deformation, the cortex and the outer lining of the periosteum is super innervated with pain nerves. So it's probably just harder to override that higher stimulus when it's being brought on. But in the same breath, we also know that, pain inhibits pain. So sometimes, if someone's pushing through it for long enough, it can also probably warm up. So I think it's probably a mixture of a lot of different things. If someone has pain that's warming up, it's probably less likely it's a fracture. But again, it's also not that uncommon for that to also still be present in a bone stress injury.
Yeah. So then speaking about the kind of the cortical and trabecular site-specific bone, would we then say that potentially there's other site-specific bones that may be more likely to warm up, say comparing a metatarsal and tibia to a femoral neck to a sacrum?
Yeah, I would say like a sacrum is probably and a calcaneus, and all of these like short, spongy bones are more likely to demonstrate warm up phenomenons just because they have more diffuse pain sensation, and the forces through them are different as well. So it's probably harder for you to have as focal a pain or as sharp of a pain. And if it's, less marked pain, it's probably more likely that you can override it and overcome it. But again, there's always exceptions. Like there's been plenty of tibias that have been like big fractures that we've seen. I think in the past 3 weeks, we've had two almost, grade 4B high grade tibial stress fractures that were completely painless, which is horrifying to say.
Yeah, yeah, it's so incredible that the body can do that. I'm just thinking we're talking about the subjective, and we've just spent 10, 15 minutes just on the warm up. We should have just titled it 10 bones warm up and just make it that topic. But
Yeah.
Question there, Beau, on that particular case. What prompted that patient to come in if they were painless?
So one of them is one of them had marked swelling. So their actual hole inside of their ankle blew up. It was originally being treated as like a tib post tendon irritation. But when it like really swelled up, they went and got further imaging and found like quite a sizable bone stress injury. The other patient, it was a posterior tibial stress fracture, and more often than not, those present as like deep tightness. So there wasn't that same sharp pain, but there was like a very deep tightness in their calf that wouldn't really go away and was easy to bring on. So they still had symptoms, but it wasn't, the classical bone stress fracture, marked pain on walking, hopping, really sharp focal pain, none of that.
Mm. It's funny that the tightness in the calf. Now, I've only ever seen one. It's my claim to fame. I did pick up a femoral bone twist injury in someone that had a foot injury, but in the foot and the ankle, the bone twist injuries that I've seen, people don't report tightness, but I know tightness in the calf is something that people do report for the tibia. Are you guys seeing this in more proximal? Like people are saying it feels tight, like basically from the foot up. That's really common for people to say, especially around the femur and the hip and the sacrum. Like I just feels tight within my hip joint or socket, or is it like it's really
There's
sharp
probably
pain?
more structures around like anything more proximal that you can like blame for being tight. Do you know what I mean? Like
Yeah.
there's not really foot muscles that you'd say, oh yeah, my intrinsics are feeling tight today. But
No one says
people
that.
love to blame like a tight hip flexor or a tight glute or those types
Yeah,
of things.
yeah,
So
yeah,
maybe
yeah.
it's just that sort of I guess there's not a clarification on what tight means. Like it might just be people misconstruing the term, perhaps.
Definitely, definitely. There's also way more referral from hip joints and hip bones and thigh bones and shin bones to other areas. It's kind of like I explain it to patients all the time. It's like when you have your GPS up on your phone and you go down through a tunnel, your phone's going to say you're over there, you're over there, you're over there, when really you're actually just deep in a tunnel and your phone doesn't know where it is. When we talk about your bones,
That's a
some
great analogy. I
Yeah,
like that. I'm going to
that
use
yeah,
that
that.
is good.
take it, go for it, run with it.
Yeah,
But
I'm
like
taking that.
the hip bone can often give you like pain sensations or that tightness sensation around the front of the hip, the groin. I've had it be referred into the lateral glute, like quite superiorly, like the upper glute, and then it can even go down into the knee and into the quad. Just realistically, the referral pattern just from the joint and the muscle and the bones can just spread out quite far. But also, if you have heaps of swelling around a bone, just like if you have a swollen knee, it's going to make all the muscles around it quite irritated. So it's not uncommon just for the actual swelling and the inhibition and the other things that are going on, the chemical irritants, to generate actual tightness in the muscles around it where it's guarding, protecting you, and responding to that chemical stimuli.
What do you think, Beau? And I'll talk about some research and then get your opinion. We do have some research to show that people training for a marathon, they will develop some tibia edema and they will develop some bone edema, but they won't go on to develop a bone stress injury. And people that generally run have some edema through their muscles and tendons and bones anyway. If someone wants to come in and they weren't complaining of any swelling or discomfort, and you were to get some imaging and see that they had edema, how would your clinical kind of decision making run through? Because we could say there's edema in the bone that may increase the risk of a bone stress injury, but we don't have any research to say that would be the case. But it's kind of normal.
So I would not be referring for imaging like MRI imaging of someone's bones without the presence of symptoms,
Yep.
bar a few sites like the hip and the anterior shin and the navicular, just because of the risk profile with those. But if I did get a scan of someone because they had some mild discomfort and there was, pronounced edema, if it's in a low risk site, that actually maybe won't lead to a huge change because if you do just have to treat it as a bone stress injury and it's more mild, it's just some general edema, then most of the time that's only going to mean they're going to miss a little bit of training and they'll return quite swiftly back to things. So I think like worst case scenario, you wouldn't be overreacting to that too much because you would have caught it quite early. It'd be quite subtle. And then I think probably the other thing is oftentimes with the MRIs of the shins, they'll actually do both sides at the same time. And if you get an MRI and both sides are very generally lit up, there's nothing focal about the edema, which you often do see in these patients where it's just incidental, like everything's a little bit white, everything's a little bit lighter, then you can basically just say, oh, there's no focal edema. It's probably not actually bone stress. It's probably just you loaded your bones. So I really just explain that to them. It's really about the rate of change in that presence of edema that will cause pain symptoms and also mean that the bone isn't keeping up. If there's just this really subtle general edema that's happened over a long time, it won't cause symptoms. If they've spiked their load, spiked how much they're loading their bone, there's more edema because there's more breakdown going on. That's when it'll be in one spot very bright and they'll have more symptoms because it'll have changed so quickly.
Mm. So we've spoken about the warm up. I guess the myth definitely that all bone stress injuries will warm up. Sorry, bone stress injuries can't warm up. The other one I wanted to speak about, I guess, is more the fact of if we think site specific, and I guess if we say kind of foot and ankle, tibia, and then more proximal, we don't really have that great clinical barrage of tests to say if you rule all these in, it's going to be this percentage increase. Say with the tibia, if you've got less than 5 centimeters and a hop, it's going to be pretty likely to be a bone stress. So the clinical do's and the fact of seeing someone, what clinical tests are you finding from their subjective purely that are going to put up your antenna for a bone stress injury?
Sorry, do you mean the objective?
Subjective. We'll get to objective. I guess
Subject.
yeah, just subjective.
Subjective is again just like night pain, resting pain, pain that's prolonged for hours or days after loading. If it's diffuse, if it's marked, if it's sharp, it doesn't really matter as long if it's really prolonged and it's over a bone. Like you have to be suspecting that there's actually some undue chemical processes that are reflective of potentially damage. If it starts becoming really marked pain, it's hurting when they're loading it. It's hurting when they're walking, things like that. Like automatically that's already a bone stress injury until proven otherwise. Like I can do the physical test, but I'm almost going to be saying in 80% of those cases, that's a situation where it's going to be treated as a bone stress injury because it's so severe. Unless you're like, they're just telling you the exact entirely wrong place and you poke it, it's their tendon and it's like really obvious. 90% of the time, 80% of the time, that's actually just going to be treated as a bone stress injury in my eyes.
Yeah, and you'll find even one of those tests. I mean, I had a previous tibia one in the last month. It didn't have really any pain with hopping, but training for a marathon, rapid increase in load, and pretty focal tenderness of the shin. And they were basically the two, or the couple of tests that we would say, this may be a bone stress injury, but there was other ones to kind of rule it out. But as you said, and I guess for people listening, would you agree that, as you said, they've got to be proven not to be bone stress injuries, and they always are until proven otherwise. Even just with one test of like, hey, I've got pain all the time during the day when I'm walking around.
Yeah, as soon as they start saying that, I'm already like my concern's quite high. Your bone shouldn't be being overloaded by walking, and it shouldn't be constantly hurting when you're just imparting like the forces that are with walking. That's moderately concerning. I would say with palpation, just because you mentioned it, I might be skipping ahead a little bit here, but
No,
I would
that's objective.
yeah. So the best paper on actually assessing palpation by Milgram et al. In I think it's in the Israeli army, I can't remember.
Yeah,
They
the
had
Israeli
like
army.
we love them.
Yeah,
There
they took them
was
for bones.
exactly they had like 410 military recruits. Of them, about 104 or 103 had tender shins, like sore shins. So it's pretty common for shins to be tender. You could say about a quarter of all active people will have tender shins. The really key thing is that they also have clinical symptoms on loading or after loading, and that it's tender markedly on one side beyond the other side. So if someone just has a tender shin and they don't have symptoms, I don't treat that as a bone stress injury. I treat it as, they have a tender shin or a sore shin. It's when it's combined with either some kind of thing in their history that warrants me considering a bone stress, or it also hurts to hop, or it hurts to do activity, and you're like, oh, something else going on here.
Is that on palpation? You were saying that marked tenderness, or more tender on one side with loading?
More tender on one side with palpation,
Yeah.
and more tender on one side with loading.
Now, run me through. Yeah, this could be a really long question. Run me through from top to bottom, or bottom to top. You've taken your subjective. You're thinking that it could be a potential bone stress injury, but you're going to go through your whole barrage of tests. What objective things are you doing? You might have a look at their joint range of motion, but to rule in or rule out, what are you doing objectively, and what do we have for the facts of what questions? Sorry, what tests are going to be best?
So, in terms of objective, I always want to see if they limp into the clinic or if they're limping when they're walking. Because again, if they're already limping, that's actually going to determine what we're going to do management-wise later. And it also raises my concern. But if we're talking about things that I do clinically to test if the bone is potentially impacted, I want them to do some forwards lunges just to see if the actual subtle impact there is bringing on some soreness. And then I'll level that up and I'll actually get them to stomp their heel down really hard to increase those impact forces. If they start complaining of like bony pain during that, that's very isolated and it doesn't really load the muscles in your calf and your shin and your foot very much when you stomp your foot. So it's theoretically at least a good indicator of whether the bone is potentially injured. If that's negative, which it often will be because it's not that actual much load through the bone, I start getting to do two-legged hops. What I'm looking for with this is I want to know how sore it is. If this is already deathly sore doing two-legged hops, I may not progress to doing single leg hops. If I'm doing two-legged hops and they're just leaning away, putting their foot out to the side, taking all of the weight off of it, I'll force them to load it symmetrically. And then if that's really painful, again, don't go into single leg hops. If we then go onto the single leg hops because they've passed everything, I'm looking for a few different things. I'm looking for either very marked pain over the site of injury, of suspected injury when they're hopping. I'm also looking for if the height of their hops is just drastically reduced. This is called bony reluctance. Sometimes with bone stress injury, you guys know this isn't more for everyone else that I'm talking about though. Sometimes when you're doing the hops, patients won't actually be able to hop. They almost like can't generate enough power to get off the ground. Their body isn't letting them load through that site because of the injury. They may not report pain, but they may have lost a lot of height on their hops, or they actually won't be able to hop at all. So as soon as any of those things have popped up, it's sore on like impact exercise, it's sore on hopping where you're loading up the muscles in the foot, calf, and hip. I'm suspecting a bone stress injury, and then I go into palpation where I'm poking anything below the knee. I try to actually poke the bone in the site that's sore and compare it between the sides. Anything that is diffusely tender doesn't actually, to me, rule out a bone stress injury. I've seen many bone stress injuries where they'll have 15 to 20 to sometimes 25 centimeters of tenderness. I think that's the most I've ever seen is 25 centimeters of tenderness. That diffuse tenderness didn't make me not go get a scan. When I went and got a scan, it actually was a big bone stress injury. Theoretically, at least, the bigger an injury, the more swelling there'll be, and swelling spreads out. It's gravity just pulls it and moves it everywhere. So I actually don't follow the less than 5 centimeter rule because to me, the less than 5 centimeter rule was actually just pulled out of nowhere for no particular reason. And then the less than 10 centimeter rule is only exists from the Milgram et al. Paper because they only had 30 bone stress injuries and none of them were over 10 centimeters. I've already seen patients with confirmed bone stress injuries that had tenderness well over 10 centimeters. So I discount that rule somewhat. And I'm just actually looking for diffuse tenderness potentially with some marked tenderness within. So if they tell me over the whole length of their tibia, it's like a 3 out of 10 sore, I'm like, okay, doesn't really rule out a bone stress injury. But if I then go through that area and there's one area of a few centimeters there where it's a 5 or a 6 or a 7 or an 8 out of 10 soreness, then I'm like, okay, that's way more likely to be a bone stress injury. So that's really how I use that rule.
What about when assessing the hip? Like what clinical tests do you find to be helpful when looking at like neck of femur if you're suspicious of, like, do you think there's any merit in looking at a fader or Faber or hip range of motion, or are you thinking that if you're getting some positive tests there, then that's more likely to be more hip joint, or is it just creating that reaction that's irritating the hip joint as well? What are you thinking when you're assessing that space?
Yeah, so there was an older study done on femoral neck bone stress injuries, and about 60 to 70% of them will have pain on end range movements, and about 60% will have pain on Faber and Fadea. So like you said, basically everything around the hip's going to be irritated when you have an injury to the femoral neck. So those things don't actually rule it out or direct your attention elsewhere. They may give you some differential diagnoses, but it doesn't help you rule it out. The exclusion to that, I would say, is if someone tells you that they only get a 4 out of 10 pain when they're doing an activity, and you do the Faber and it brings on the full extent of their pain, then you're probably more confident that it is due to actually the joint, like specifically, or if you're doing resisted muscle movements of their adductors or their hip flexors or their abductors, and that's bringing on the full extent of their pain, it's more likely that it's due to those structures because realistically, the bone's not loaded much by those things. What we normally see in femoral neck bone stress injuries is that they'll tell you they have an 8 out of 10 pain, a 7 out of 10 pain when they were running. And you go and you do these assessments and like, oh yeah, it hurts. But it's like a 2 or a 3. So you're doing all these movements, all these things to try and stress everything else in the hip, and nothing brings on their symptoms to the full extent, that's a situation where you're like, okay, this is probably the bone. It's
That's
really
a great
via
answer.
exclusion.
Yeah,
Yeah.
I feel like it's quite tricky because there is so many possible differential diagnoses, but then it's also such a high risk injury. So it's almost like if it's a runner with anterior groin related hip pain, it's so hard to try and convince yourself to rule it out based off your clinical testing. It's probably not worth it even, but yeah, that's really helpful.
Yeah,
Yeah.
I do think probably 1 or 2 times I've had a patient where they say it's like a 4 out of 10 hopping, and I'll do a Faber and it's way more sore doing Faber or Fadia. And then I'm like, okay, it's actually probably your hip joint. If hopping doesn't hurt as much as this, then it's probably your hip joint.
What is truly great is what we are talking about. If you are listening to this potentially as a runner or non-health professional, all these clinical tests, some you obviously can't do, but certainly from the subjective history and purely just what you're saying, like if you're doing a calf raise and then a double leg jump and a single leg jump, and you're getting positive symptoms and you have soreness all day, you really do need to get it assessed. And as we'll speak about why it's really important to do that. But these tests and purely from the history really give you a good idea of what's happening.
100%.
Yeah. Are you aware of any papers that have the barrage of tests together and that increases your suspicion? Is there anything out there for any other areas like in the hip or the tibia or the foot, or it really is, picking these ones that we know are going to be most likely to be positive and then making your clinical decision?
So because a lot of these injuries are so like rare and poorly studied, it's hard to have enough patients to actually go and do enough MRIs and then go and do enough clinical tests and then put it all together. There's actually not much. So for the tibia, I think they said palpation of less than 10 centimeters and painful hopping. Combining just those two things will catch all bone stress injuries, but about 55% of the patients that are positive on that won't have a bone stress injury. So the sensitivity is 100% and the specificity is 45%. For the femoral neck and the sacrum, everything is really just kind of case series, or they've done assessments on patients, and out of the patients that had these injuries, the percentage that was sore in these tests is documented, but there's not actually like really good diagnostic clinical research out there to tell you which tests are like absolutely perfect and which ones are not. Other than saying a few tests are useless, like the fulcrum test and the tuning
No.
fork test. Sorry, guys.
Oh, wait,
Sorry,
I did the
guys.
Fulcrum. So when Kelly had that, I think it's episode maybe 94 when we spoke about Kelly's bone stress injury, but it was when it warmed up and things. But the Sunday we went for a big long run, and on the Saturday, Kelly was like, "Oh, my thigh is hurting," and I, with my proximal diagnostic skills, thought, bang, I'll fulcrum this bad boy. And I don't think I had any pain, so it was sweet. So you ran 29K because my fulcrum was negative.
It's the next day, no problem.
Yeah, so I probably
Warmed
could have.
up, it was sweet.
Yeah.
MRI later was like, maybe not.
Yeah, something
Maybe
going on
not.
through there. Yeah. Now the other fact, which is really important for people to understand, is that one, all bone stress injuries are not the same, and two, there are serious consequences of running through a bone stress injury and missing a bone stress injury. So we spoke about the potential for lots of time off, the cost, the time, the energy, the mental health challenges. What would you add to that, Beau? Why is it important that if you are suspicious or you think that you have some of these symptoms to get it assessed, and if you're a clinician, why is it important to not somewhat rule it out and say, I'll just see how it goes and we'll catch up in 4 weeks or a couple of weeks?
I would probably say all of the reasons you listed are more than enough for that to be the case. If someone's going to miss, potentially months longer because they keep running on something, they're going to spend a lot more money getting treatment, get a lot more imaging done, or just miss out on what they want to do for longer than they need to. I think all of those things are enough of a reason. But the reality is, in the position that I'm in, where I see as many bone stress injuries that I do see, I've had low risk bone stress injuries to the pelvis and to the metatarsals actually become completed fractures where they've displaced and moved and are very gross. That's a situation where a displaced fracture is one that has completed, so it's broken the whole bone and then it's moved. Most of those have actually required at least surgical consideration, and they actually put at risk all of the nerves and blood vessels around the bone. So the reason that we care so much about these injuries is you can push them to the point of them being potentially devastating. And if you have a displaced fracture of any kind, of any risk, it's automatically actually very high risk and very troublesome to get back from. There's no data out there at the return to sport rate, but I guarantee it's terrible. So let's not go there. Let's not push to it. It's in no way fun.
Yeah, we were talking in the car on the way home from where were we? I don't know, somewhere. We were driving home. We were like, man, we're never going to miss a bone stress injury. We might overdiagnose, not overdiagnose, but over-investigate like 50%. But I don't reckon we'll ever miss one because we're just so like antennas are up and it's just such a front of mind injury for both of us. Like I reckon we'd talk about bone stress injuries at least once a day.
Yeah, well,
Yeah.
seeing, I mean, you would say if you've seen managed runners, and we know up to 20% it could potentially be, and we know the consequences are so high, it really does just kind of fit the bill. Like you just have to be, otherwise you can really get caught out. And it's a crappy feeling as a clinician, but it's even worse for the person that's suffering it. And you both, I'm sure, would have seen people that have had them missed, and you hear their story, or they've been trying to get back to running for a year or 2 years, and it's really horrible, and you feel so bad for them because if it was picked up, a lot of this potentially could have been avoided.
Definitely, definitely. And I think for the high risk injuries, because sometimes their symptoms are really quite difficult, they're even harder to pick up. Like anterior tibias are often missed for on average, 40 days, but sometimes they can be missed for 2 years. That's a situation where, that person is probably going to need to get a surgery and miss out on months and months of treatment. But even just in the low risk patients, it's really easy to go from a stress reaction to a much higher grade bone stress injury. It might only take you like a week of loading for it to become a fracture. It might have only take you a run and a half for it to become a fracture. And if it does, it's probably going to double or triple how long it takes you to get back from that injury. So we're talking about such a fine line of how much we can get away with in such a short period of time for such a high cost later on. Just it's so good if you are treating runners or patients that are at high risk, always have the antennas up, always be looking for them.
Now, I want to give you a question. Somebody comes in with shin pain. This is all the
Stress fracture.
information.
Oh, sorry.
I was going to say, this is all the information you get. Is it MTSS, aka shin splints, or is it a tibial bone stress injury? How are you going to run through, I guess, in your objective? Because as we said, and I guess some of the subjectives as well, because you can have similar symptoms and similar report of symptoms with both of those conditions.
I actually am totally on the fence as to whether MTSS and bone stress injuries are different things.
No, you're not allowed to be on the fence in this podcast. You have to have
Let
no nuance and just say it straight out and go, don't ask me any
Okay.
questions. This is right.
Let me finish. Let me finish. If it's focally sore ever, even if there's diffuse tenderness, I go it's bone stress. If it's really diffuse and there's no focal area that's markedly sore, and it like does warm up and it doesn't get worse and there's not prolonged pain afterwards, there's no night pain and stuff like that, I'll absolutely go fair play. Let's treat this as just like a irritation to the structures on the inside of the shin. If it doesn't have any of the other like really cardinal bone stress signs and it's diffuse and there's no marked tenderness, play on, let's do it. But if it's at all focal, if it's at all like, giving you that night pain, resting pain, anything like that, boom, bone stress injury, prove me otherwise.
And bilateral symptoms sort of point me towards more shin splints or MTSS than stress fracture. I feel like that's quite uncommon to have a bilateral stress fracture.
Yes, very true. However, on the flip side of that, I've probably in the past 6 months seen about 8 bilateral bone stress injuries. So they're definitely not impossible. Sometimes it's even they get them on one side and they just load up the other side and just get it right after.
Yeah,
They'll swing between them.
Now, I want to bring 2 myths into one. We're going to join together. Like there was that card in Yu-Gi-Oh! Where you could combine 2 monsters together. And I think it was maybe I can't remember what it was, but it was a really cool card. It's a powerful card. So, myth 1, that all bones are built the same. And myth 2, it is all related to load. What would you say to the all bones are built the same, and why some people may be more at risk if we're looking purely from morphological shapings of bones?
Do you want to take this one, Kelly? Do you want to start off?
You go first, Beau.
Okay.
You'll have a
I
better
would
answer than me.
no, what? This is a collaboration, mind meld. Remember, we're combining all of this. Um, I would say generally, not all bones are the same. There are certain types of bone that, don't have as good a blood supply, are subject to very different forces, or are just made of different, basically, compositions. If we talk about sites that are relatively similar but actually aren't treated the same, we'd be talking about the cortical bone of your shin. If you have a bone stress injury to the front of your shin, the forces are tension based, it pulls it apart. And if you have a bone stress injury to the back of your shin, it's pushed together. So if we talk about a fracture, most of the time after you have a fracture, you get a cast and it holds it together for you. A bone actually can't heal and it can't respond and can't adapt at all to tension forces. So whenever we have injuries to the front of your shin, even though they're made of almost the exact same bone, they have relatively the same orientation in the body, they're basically just completely different sites and managed completely differently. So the time frame for you to get back from a posterior tibial stress fracture on the back of your shin, it might only be 12 weeks versus the front of your shin, it might end up being a year, might be 12 months. It's exponentially longer for you to get back from it. So that's probably one takeaway would be what forces are applied to it. If we then also look at the actual type of bone, trabecular bone, so spongy bone that makes up short bones and the ends of your long bones, it tends to take a lot longer for that type of bone to remodel. So trabecular bone takes about 200 days to be completely replaced after it's been damaged, versus cortical bone takes about 120 days. So it's almost half as long for it to be turned over and replaced. So already those two, very different camps. If you look into the studies that give you prognosis of bone stress injuries, it does take about twice as long to recover from a trabecular bone injury. Even if they're both low risk, if they both have good outcomes, trabecular bone just takes longer to heal. That's not just because of how the bone is structured and how long it takes to heal. It's also because long bones like your tibia, your femur, and your metatarsals, they get these like big, beautiful calluses, these big bumps that form on them that buttress the fracture and hold it together and actually can strengthen your bone up really quickly. They've done some very mean studies to some rats and basically shown that after you've, poor rats, honestly, after you've broken a rat's bone, it can actually recover strength by 80 to 100%. So it's almost completely healed in 1 to 2 weeks just from forming a callus. So if we have a cortical bone, they develop these awesome big calluses really quickly. But these trabecular bones, they develop these tiny little, not useful, good calluses throughout the bone that just doesn't give it the same strength. So for so many reasons, those two sides completely different. Even though they might both be low risk and easy to manage, one's much slower.
Yeah, we need to really dedicate some time and energy to thanking the rats that have been put on show for bone stress injury and the
They've
Israeli army.
sacrificed a lot for
Imagine
us.
being a rat in the Israeli army. I mean, you're going to learn a lot about bones, but you're not going to have a very good time there because they just do some wild and lovely studies. But I wanted to ask you, Beau, you did raise a really interesting point around, say, the anterior versus the posterior. If the tensile forces, which we know are going to be higher on the anterior, it would make sense that potentially it's, as in, you're going to be pulling those bone cells apart. Why do we not see injuries there compared to at the back where it's more compression and they're going to be coming together
As much.
as much? Yeah.
That's such a good question. I genuinely do not know at all. I think it seems as though there's some people where they just are predisposed to loading the front of their shin more, because why wouldn't those patients just get compression-based injuries at the back? It's really unclear. It might be how they move, it might be how their bones are orientated, it might be their blood supply, it might just be bad luck. I really have no answer for that question, unfortunately.
I always wonder that with the metatarsals as well, like dorsal and plantar, but it is interesting.
I think the only other thing that I was going to add to what you were saying there, Beau, as well, between the cortical versus trabecular bone obviously being different and trabecular bone taking a lot longer, it probably also comes down to potential risk factors that might have contributed to that bone stress injury coming about in the first place. So it is not uncommon for someone with a trabecular-rich bone stress injury to also be experiencing low energy availability and REDs, and those things also need to be addressed, which takes time for those bones to have a good prospect for healing. So it's not just relying on that bone turnover, it's relying on addressing that energy imbalance as well, which could also prolong that recovery. I would say there's factors like that involved, but I don't think I think that would be really hard to measure or like actually research that.
Yeah, no, I definitely, as soon as someone has particularly multiple trabecular bony stress injuries, either a history of or presenting at once, yeah, like red S is much more common in those sites. And not addressing that, I think, I'm not sure if Blake's the person that said this, but sometimes if you do all the correct rehab, it won't matter whatsoever if you don't actually address their fueling and their low energy availability, because bones just can't heal without resources to rebuild and energy to do so.
Yeah, they did that study in male runners or male cyclists, where they looked at giving a group resistance training versus not, and then controlling their energy imbalance. And the people that were below their energy availability weren't actually able to build bone mineral density, which is what I wanted to talk about when saying that all bones are not the same. We know that some people just genetically have bigger bones, whether it be from purely their genetics or the environment, the nature versus nurture discussion. If people play multi-directional sport when they're younger, they're a little bit more likely to have a stronger bone and potentially, a bigger bone and potentially a lower risk of injury. But one conversation that you and I have quite a lot when we're looking at the research is a lot of the research talks about BMD, which is bone mineral density, which is certainly an important measurement and it's an easy measurement to do. But probably more so, what is more important is looking at the actual shape and size of the bone. What do you have to say about that?
Yeah, so density is definitely important. If you have a denser bone, it's going to be stronger. But the relationship of the forces that go through the bone and its tolerance is much more drastically impacted by how wide a bone is, particularly in the context of long bones. So again, like metatarsals, tibia, and femoral shaft. What we see is there's this exponential relationship between the strength of the bone and the width or the radius of those long bones. So very small increases in the width of a bone can skyrocket how strong your bone is. Now, there's not awesome evidence to show that that's the case in humans. It does seem to be less exponential. Rats, because they're smaller little creatures.
Yes, go the rats.
Yeah, like a 1% increase in diameter of your bone in a rat will 100-fold the strength and 10,000-fold the failure loading rate that's required to, like, in rats, it's superhuman.
Man,
In humans,
You've
I know
got
now
rat
now you
bones.
wish,
I've got
yeah,
rat bones.
exactly.
You've got a rat wrist.
No, I mean you've got thick bones.
Oh yeah, okay.
I feel
I
like
thought you said I got small bones.
I've got like mouse bones.
So that's the only time you'll ever say you want to be a rat, by the way, Blake. You were just giving them a moment of silence, but
Jeez.
in humans, a 1% increase in like diameter of the bone seems to still give you marked increases in strength, but it's not at the same exponential rate just because we're bigger. I still think, yeah, if you can get wider bones, there's good research that in army personnel, female and male, thicker bones tends to reduce your risk of bone stress injuries drastically. So when people say they're big boned, you actually want to be big boned in this
Yeah, how do you
situation.
go wider, not just
Grow wider.
denser?
I would say it's actually the same principles. You just load the absolute smack out of them, and eat well and make sure you're getting enough vitamin D and calcium, and that should give you the best opportunity to improve your thickness. I think a lot of the research only does like bone mineral density. If they had tracked width, it probably also would have increased.
Yeah, it's not something that's talked about that much. Hey, like I don't really, I mean, maybe it's because I guess they could just do an MRI and measure the size of it. But yeah, I don't often hear the width being discussed. It's often
it's a
just
lot
the
harder.
density.
Yeah, I spoke to Virgil about this.
Oh, okay.
Yeah, it's a lot more typical. And there are tests that you can do around with CT and to work out different parts of the bone. It's just a lot more typical, a lot more expensive, more ethical approval. Whereas BMD is just a little bit easier. And
Just
it's a lot
an X-ray.
a lot better validated as well.
Yeah.
Yeah.
So I think it's normally micro CT that they do to measure the density and thickness when they do like these crazy high-tech studies.
But it would be so good because then, like, we talk about a lot, and so do you want on socials around, there's not a whole lot we can do to reduce the risk of running related injuries. And there's not a lot of research, especially in the tendon space, to look at the morphological thing and internal structure of the tendon, and then be able to say, yep, your tendon's thicker, or you have this much healthy tendon. That means your risk is going to be lower, because we know that having degenerative parts versus healthier parts doesn't seem to make much of a difference for rehab. And we know that other parts of the tendon can be as strong as that and make up for it. But when it comes to bones, it makes logical sense that having a wider or a denser bone is going to increase the failure rate, and it's going to then, in turn, hopefully reduce the risk of injury.
Just correcting you. You said increase.
Oh, sorry, reduce. Yeah, sorry, reduce the failure rate. Which is that the failure rate for the bone? Is that what failure rate is? The failure until the bone to fracture? Is that what they mean by that? Like, would that be the goal?
So generally, when they do these tests on failure rate, it's either projected failure rate, like probabilistic failure rate, where they just assume it will break after this many cycles based on tests they've done, or they actually just take the bone and bend as many times as they can until it breaks.
Yeah. All right, myth again. I haven't had much fact. A lot of myth.
A lot of myth.
Myth, you should be guided by pain guided rehab. So the typical scenario, and we're going to do another episode talking about I guess more so the management, but someone's been managed to the point where now they're pain free out of whatever load reduction strategies you have used, and they don't have any pain. They should be able to be guided to the point where they can get back to what they want to be able to do, and then that's it. And I will say, Beau, one of the things that you mentioned at the course that we did with the running room, which has really stuck with me, is when we talk about managing ACLs, we're very, very clear from the start and saying this could be a 9 to 12-month journey. I think, is that what you guys are saying? If you physios? Yeah, just making sure. I've never told anyone that in my life. I've never seen an ACL, but we're telling people from the start it could be a 9 to 12-month journey. But when it comes to bone stress injuries, we don't say anything like that. We usually say you'll recover, and then you'll have a period of building back to where you want to be able to be, and then we'll just leave you alone and you get back to normal. Like, why isn't that the case, and why can't we do pain-guided rehab?
Well, I think you definitely can do pain guided rehab for a lot of patients, and that's a good way to roughly gauge their progression. It's much like doing criteria-based rehab in ACLs. If someone does absolutely smash every single test and they look awesome, they maybe can return to sport faster than that 9 to 12 months if it's worth the risk for them. And in bone stress injuries, there are some cases where you probably can, but I just don't think we have clear enough criteria for performance metrics to indicate how strong the bone is, measures of the bone strength, or anything like that to really give us, absolutely clear cut, definitely like can get back to the sport as fast as you want. And the recurrence rates are super high, like 33% of patients, if you include both sides of both limbs and all sides, 33% of patients can have a recurrence of a bone stress injury. So that recurrence rate and the time off is just super high. I think taking longer is always better. There's some research to show that in female military personnel, after having a tibial bone stress injury, their bone mineral density plummets from week 6 to 12 after they've been diagnosed, and it takes sometimes 6 to 12 months for it to restore. So if you're dealing with a population where they have actually lost a lot of bone mineral density and you're trying to get them back to running at 12 weeks, that's probably when their bone's the weakest. And then if they're running even more at 6 and 12 months, more than they were when they had the initial injury, they're probably running the risk of having another one, much more so than would be the case for other people. So I think there is a situation in this, and there's enough reasoning to say that 6 to 12 months to return to full performance is not a bad idea, particularly in patients that either had to go in crutches, had to go in a boot, or just had a very high grade bone stress injury. You probably actually should just give them more time to reduce the risk. Because there are a lot of ACLs that actually could go back, but they don't because it takes so long to get back, and it is financially quite difficult. And the risk is very high if you return them earlier than they need to. Just because we don't have that data as clearly in bones, I don't think that's the case yet. But I think, in 5-10 years, that may be the case where most bone stress injuries are treated like ACLs.
I should clarify, definitely agree. Pain doesn't equal the strength of the bone, and it's very common for people to get back relatively soon. I think that's a time frame of 6 to 12 months to get back to full activity. Say for a runner, would you be telling them that, say for they want to get back to 80 kilometers, that is a reasonable goal, or do you think you can return somebody earlier?
I think you can return somebody earlier if you do the right things about maintaining bone mineral density. So that's where starting to optimally load them as soon as possible, as symptoms and their case allows. Like if you can start them walking without a boot sooner, if you can start them doing some weight bearing exercises and some heavy calf raises and some impact work sooner, you're going to mitigate how much bone loss they have. The issue is, as you do that, you're also running the risk of flaring up or potentially slowing down healing. So you have this kind of fine line that you're treading in this early stage, where if you do it correctly, you're going to mean that they lose a lot less bone mineral density and you don't have to wait as long for it to come back and you can go back quickly. I think if you're being like an older school traditional physio and you're just putting them in a boot for 6 weeks, no matter what, and not doing anything to prepare them for even getting out of the boot, I've had many patients that have been referred to me that have actually gotten bone stress injuries after getting off crutches, after getting off a boot. They actually get one just from walking around or just from starting to do some impact loading. The immobilization that we give these patients to protect them is also a disadvantage in the long run if we're not doing things to manage that, or at least manage our expectations later on.
And you can load other parts of the body. If someone has a below knee or above knee, you can load the other part or the other limb, and you can load it quite easily.
Yeah, definitely. I mean, even axial load is probably pretty safe in most bone stress injuries below the knee, just because muscles are normally the things that are loading the bone a lot. So axial load is going to be pretty safe, and it will give them some stimulus, and then you can gradually add in some muscle forces later on. So I give patients after tibial bone stress injuries like squats, weighted deadlifts, same for metatarsals, just as long as it's not, they're not pushing really hard in the boot or pushing really hard on the floor. Most of the time, those can actually be quite safe and easy ways to keep their bone mineral density quite high.
Yeah, there definitely is more thought around that we probably were protecting them a little too much with what we were thinking, because I guess if you put them into the camp or they have a fracture or they're about to fracture, you are a lot more conservative with that. But when we think of, as you said, the strength that you can have in the bone is very unlikely to break if you're loading them clearly and you've got good evidence from a clinical test and about this person that they do still have a pretty strong bone.
Yeah, and I think that's the case for a lot of these patients. The caveat to that I would say is if it's a femoral neck, if it's an anterior tibia, though, and a navicular, almost any force through those, and they will not heal well. So that's almost the complete opposite, where you just actually have to be ultra conservative. So it's really about knowing when it is safe and when you can go. And red S is and low energy availability is a huge part of that as well. Because if you're trying to do these optimal loading strategies with someone and their bone just doesn't have the fuel to adapt, you're probably actually making it slower. And likewise, if the patient has no pain warning system to tell you that their bone is being overloaded to protect them, you're likewise again going to overload it and you're going to actually slow things down. So it's recognizing those factors and then knowing when you can be safe and going hard when it is safe.
What would you say is the best osteogenic activity that someone can do? I guess, let me rephrase that question. What can someone do to continue to maintain and build, we say, bone mineral density long after they have returned? Because as health professionals, talking about, things that are potentially pharmacological and more systemic, we're not usually the treating clinicians. We might help someone in the diagnostics, but usually referring someone off to do more of the therapy and the treatment. So what can we do?
Exercise wise, I reckon you want to be picking between kind of three options here, which would be like, first off, just a caveat, running's not good for your bone mineral density. It may very slightly increase it, but it's not actually your rehab. It's just the thing you want to get back to. Running itself is not actually great for building bone mineral density. We want to pick things that, yeah.
So I was just gonna add to that, because I did read something yesterday. And you said the caveat as well is it's slightly better than not doing anything at all,
Yes.
but it is not good in the sense of it's a great for building BMD. And when they've done studies looking at resistance training, they have a group that does resistance training, a group that doesn't do it and just runs, and then a control group that does nothing. The group that just runs and the group that does nothing have relatively about the same BMD or just a little bit higher. So
Yeah.
as you said, it's not ideal.
No, it's not. So I would be opting towards one of two strategies, or actually ideally both. I would be including heavy resistance training that imparts high muscle and axial forces to the area that was injured, and just honestly to every area in your body after you have a bone stress injury, just make your bones like bomb proof. And then I would also be at some point including quite intense plyometrics at a low dose. Bones respond to the magnitude of the force you give them. So something that's just really high load, they'll love. Like that'll really give them some juicy stimuli to get better. But they also respond to high loading rates, so things that are quick and fast. And if you combine the two in their high loading rates and high magnitude, like in a plyometric or a jump, it's generally going to be really effective at improving or generating what we call osteogenesis and getting our osteoblasts to build either new bone or strengthen up our old bone. I would say those two things are the best. If you had to make me pick a specific exercise, I would just probably say heavy calf raises for a tibial bone stress injury, and a metatarsal bone stress injury. Anything around the ankle, a heavy calf raise is going to be the best. And then like multi-directional pogos, hopping on one leg and going in lots of different directions, some variability there. Those will probably give you the most bang for your buck. If it was your hip or anything like above the knee, I would be saying probably some form of staggered stance or single leg deadlift that's heavy load, and then some form of varied hop, like jump on one leg, that where you're bending at the hip and knee and loading up those muscles as well.
Yes. Now, clinical scenario. Someone has had a bone stress injury. You've taken them through the rehab. They're so grateful. They go on to win the marathon at the Olympics. And then they come back and they say, I'm doing really well. Don't have any pain. What should I be doing for the foreseeable future? Do we have enough research, enough clinical decision making skills to be able to say, you probably should be doing some form of osteogenic exercise for your running career or for the foreseeable future? If the goal is to, say, two groups, recreational runner, and then also someone that wants to do performance, because the argument is that, well, I can't run more if I'm substituting that for resistance training.
I would say absolutely they should do resistance training with some plyometric activities. Number one, it actually improves performance very consistently in the research. So it makes you faster. If it's not eating into your resources fueling wise and volume wise training, you absolutely should do it. I think a lot of runners get caught up in the initial training stage of adding in resistance training, where it does reduce how much you can run. But when you're a seasoned runner and you've been doing resistance training for a while, if you structure it appropriately, it shouldn't eat up too much of your time and shouldn't eat up too much of your resources for running. There's always going to be a little bit of a trade-off here. You'll probably get more out of doing 40 minutes of resistance training a week, 20-minute blocks, than you will doing an extra 40 minutes of running, because it's just going to give you something completely different. And in the case of a bone stress injury, you absolutely should be doing bone loading exercises to stimulate bone adaptation for the whole 6 to 12 months since when you're recovering from it, and just forever afterwards, because you're at such a high risk of having a bone stress injury afterwards. We just want to do everything we can to reduce the risk. Like we said, these are like the ACLs of running injuries. Why would we even risk it all bringing one of these on again?
Especially when there's so many great, well-documented benefits attached to resistance training for tendons, cardiovascular health, metabolic health, as well, aging, masters athletes. It's really somewhat the closest thing we have to a panacea to be able to help
Yeah,
someone.
especially if you combine it with cardiovascular fitness. It's so good for you.
Yeah.
I have a question for you, Beau. It's something that I've been doing a little bit of research on recently, and that was something that I haven't actually looked into too much in the management of bone stress injuries until within the last month or two. But I was looking up anti-gravity treadmills and if there's any use for their implementation in the management of bone stress injuries. And what I found is that there isn't any RCTs that have been done in bone stress injury management. There's one like pilot case study, and it followed this elite runner through, and she had a successful outcome. But what I did come across was 2 RCTs. One was in an Achilles rupture case, and then one was in an acute tibia case, and it had a control group versus anti-gravity treadmill in trying to build back back over ground running. And there wasn't much in the between group differences. So I think the intervention group in the Achilles case got back like 1 day earlier than the over ground running group, or without the use of the anti-gravity treadmill. So my takeaway is that there's probably not much use for it at this point in time from what we know. But is that something that you would use, or is it something that anecdotally you have found to be effective in particular cases? What's your thoughts?
I've found it's very beneficial in the cases where patients like need to run. Those patients that are just, absolute frothers, they have to exercise and they have to do, like, running is a huge part of their identity. I would say for those patients, and also for very high level runners, those small differences are probably going to be more impactful, especially if they have access. I think it's something that could be very, very beneficial for those cases. What I would say though is most of the time doing progressive resistance training and doing like alternate aerobic training, be that, seated ski erg, swimming, cycling, elliptical, rower, all of those things can keep up enough fitness that you may not need to be doing running. And if you are running on an Alter G, it can sometimes alter your running mechanics quite significantly because you just have less body weight. It may not end up being a really good cardiovascular stimulus. And we've just spoken that running's not like an awesome stimuli for bone adaptation. So if it's not actually replicating the mechanics of running itself, if it's not providing a good mechanical stimulus to the bone, and if it's not providing a good cardiovascular stimulus, I would say on the whole, it's not going to be the best choice to take up a huge chunk of your rehab. In patients where you just need to get them running sooner because they're elite, because they're, absolute frothers and they need to run, they have, some mental health components to this, I would say it's extremely invaluable. But I think for the majority of cases, there's a lot of caveats to why and how it would work the best.
Okay, good answer.
Yeah. Have you referred anyone for that? Has anyone asked you about it?
I've only had one patient I've referred to that, and one patient that has just gone and done it. I actually think it's really helpful in ACLs. I think it's really helpful in osteochondral injuries, and in like gross bad bone stress injuries. I think it would be really helpful because it might even just tell you that they're going to get symptoms sooner. Like most of the time, return to run programs aren't actually rehab. They're just monitoring tools. You're controlling how much they're running just to actually make sure they can tolerate it. So like the Alter G might just be a really early way to gauge if they can progress quicker. Because if they're running at 60% body weight and have absolutely no symptoms, you can progress them to 70% versus, going from no body weight sitting to running is a big jump. So you might just be more confident you can progress quicker using an Alter G.
Yeah, I like what you said about return to running and running not being a great stimuli, because I know Greg Lehman, which is a really interesting thought to have when someone wants to return to run, that you can just dose them with running. So they don't need to do any rehab because you can use the running as their rehab and progress that because that's the activity they want to do. And I guess bone stretch injuries are somewhat the caveat to that because we know that running may be slightly a little bit better. And if we compare groups, we know that running and resistance training have bigger bones, stronger bones. So it's probably not a good idea to just do running on its own because it is a stimulus. They need to have something else attached to it that is osteogenesis. That's another myth busted.
Yeah.
Busted.
I would say strength training, like gym, is actually way more important than running. Like if someone tells you they can only work out 4 times a week, like 2 of them are gym at least. If someone can only work three times a week, 2 of them are gym.
Let me ask you something unrelated that Kelly and I have had many a discussion about. And we're not going to get into it unless you agree with me, because if you don't, we'll just move on.
Okay.
Would you consider plyometrics under the umbrella of resistance training, or is that a completely different kettle of fish?
I actually, yeah. I don't know. I mean, you're not adding extra resistance, but you are increasing the internal loads. You're not changing the external load, but you're increasing the internal load. So I don't actually know. That's some
I don't even
semantics.
know what my answer is. What do I normally say?
Because I would call plyometrics I say resistance training, and that would include weights basically and plyometrics. But you would say that plyometrics is out of that because resistance is like you have an external load applied to you. That means, well, then walking is resistance training, and that's not what we mean. It's adding external load because then plyometrics is not because you're just using your body weight. But then you could say that doing a body weight calf raise isn't resistance training because you're not adding external weight.
Mm.
But another topic, interesting. Leave it.
There's
When
a
we come.
there's a systematic review on this, so it actually will tell us the answer. I will find it later, and it can qualify.
Yeah, if it agrees, definitely send it through. If not, don't worry about it.
Oh, sweet. Yeah.
It's allowed
Yeah.
for discussion. Now, are there any myth or facts that you think that we haven't covered or that are worthwhile that people need to hear before we come back? Because there's lots that we haven't talked about, which we will talk about in other episodes of site specific, what rehab and how to program that. Imaging is a big one. I actually had the flexing physio send me a message on Friday. I was on the train going to uni, bang, voicemail from Dan, and we were talking about imaging for bone stress injury. And I said that Beau and I have a very good discussion around this because we agree, but some things we disagree on, X-ray versus MRI, but we can't get into it now. We're going to have to probably make that a whole image because that's a really good conversation.
What a cliffhanger to end on.
I should just.
Are you trying to bring them in, hey?
Well, it's a really good. I guess it's more that the goal of that conversation would be there are cases where one is better than the other, and I definitely agree that MRI is probably overused, but there are cases when we do use it, which I assume you would feel the same as well, where it is definitely better. And then talking about CT and things like that as well.
Yeah, definitely. Another argument that we have to set up, just really get everyone
I know what you're
juiced
gonna
up for it.
say.
Mate, running soft is probably not.
Oh yes.
We have to go hard on that because
We
I
have to
think
go
we
on the
do
running
disagree.
softer. Yeah, we're
Yeah.
doing the course. I'm like, yeah, this is what happens running softer. Beau goes, don't listen to that podiatrist down there. Running softer will increase bone load. But that's
I would say running softer would increase bone load.
well,
Yes,
What you would
Kelly.
say?
yeah.
Yes.
I was in reference to a study, but I'll explain. We're not going to talk
No,
about
no.
it
Don't
now.
bring the nuance.
Yeah,
This is just
there's
fisticuffs.
no nuance there.
There's no nuance.
Don't bring the nuance in. Now, we will, of course, have introduced you at the start of the episode, but if people want to be able to find you, where's your address? Where do you live? If they have pain in their shin, where do they go to come and see you?
Well, please don't come to my house if someone has
Just
DDoS
knock
me.
and go, I've got
Please
night
don't.
pain. What's going on? I just listened to the episode.
At 3 a.m.
Yeah. I've got a marathon tomorrow.
No, please don't do that. Only Blake is allowed to do that to me. But definitely just shoot me a message if you have any questions on Instagram at Stress Fracture Physio. That's most of where I live and do most of my communications with people. If you do live in New South Wales or Sydney and you have a pressing injury, particularly a bone stress injury, and you want some help, the crew at the running room are excellent at managing them. Come see anybody there. If you really want to come see me specifically, go hard, come chat to me. I would love to talk to you about your bones.
And I will add that your clinic is pretty cool. Like you've got a big rehab space. You've obviously got the credentials, but you've got a big gym. You've got the Zebras treadmill as well. So it's, yes, the diagnostics, but the long-term management, running assessment, run programming. It's pretty much an all-in-one stop shop. And as you said, you work with lots of other cool clinicians, dietitians, sports doctors. So it's pretty well positioned to help someone if they really are struggling. And
Definitely.
do you do any online stuff? Because we do have, surprisingly, we have a lot of international listeners. Like I actually thought that it would be not this country, but we have a lot of people from the US that listen, and Britain country, UK.
I don't know what you're asking me.
Yeah, and the UK. So people might be listening that potentially want to have management. Do you do any online stuff?
Yes, so you can see me online through the running room. I treat people pretty much all around the world, all throughout Europe, in America, all around Australia, and some people in Southeast Asia as well. So, realistically, we can do 90% of what we would normally want to do via telehealth, and anything that we really do need to do in person, I can get you to go see someone else or set something up for you.
Yeah, great, mate. Thank you so much for coming on, and we'll be looking forward to having you back very soon.
Yeah, episode 2, fisticuffs. Let's do it.
It's just a boxing match.
Just a boxing.